Right, we are live. Please give me few minutes while I try to sort out bit of my background work. I always say because I need to share this with other platforms so everybody can see me and understand what I am doing. So if you could give me few minutes, everyone, I won't be long. Let me just share it, and we would be up and running. Just let me share it so every one of you will have access to. So let me share it on one platform. Right. Let me share it in another platform and one more platform, and then I'm done, hopefully. Let me share it with another platform and one more. I want to share it in my Bengali program, which is I've got thousands and thousands of viewers throughout the world. Right. Absolutely. So the more they know, the more better it is. Right. Okay. Okay. Good evening, everyone. Today is Thursday, 4th of June. How quickly June is gone. 2020, Vision 2020. Today is Vision 2020. Today it is a imaging. And I have a colleague of mine, right? He himself soon will explain who he is, what his background, and then we'll kick off. By the way, my disclaimer before anybody bites me, right? It's a disclaimer. If me or my guest say something or does something, right, which is not relevant or misleading or misconception, please forgive us in advance. Apologies, right? It is a live. Live has no script, right? Anything can come out from our mouth, right? So there's therefore no biting, please. Apology in advance. Anything happens, any mistake we make, always let us know, and we will try to correct it as much as we can. We are human being, right? Yeah, so therefore please forgive on this aspect and apologies in advance. Right, anybody who want to ask a questions, it's your chance, but you need to ask the questions on my Facebook profile, because I have shared about 5 or 6 platforms. If you make a question there, I won't able to see it. Plus, we are broadcasting on YouTube as well. If you type my name in, my brilliant name, famous name, Somus Mia, you will see on YouTube. Okay. So, as I said, let's kick off. It's about all about diagnostic ultrasound, right? We got a lot to learn, lot to think about, lot to know, lot of misconception, lot of this and that. So let me now, as everyone is waiting, right? We're going to go to my colleague, right? Good evening, Adrian Berman. If you could introduce yourself, who you are, what you do, where you're from, which planet Earth you are from, and we'll kick up from there. Thank you.
Yeah, thanks so much. Yeah, so as said, my name is Adrian Berman. I'm a sonographer. I've been a sonographer for 13 years. I've been in imaging for about 17 years now. I worked out the other day, which was a bit scary. But ultrasound for 13 years. And I'm currently working at a local NHS trust as a locum sonographer, but I also do a bit of private work as well. So a little bit about my background and when I got started. It was back in about 1998, I think, where I first took on a sports science degree.
By the way, I already have one fan from I remember I said I've got 300,000 followers throughout the world. Yeah, Ahmed Moshrai. Thank you very much. Bye. All right, go ahead.
Yeah. So I started with a sports science degree, actually, a bit like, and I wanted to be a physiotherapist.
Okay.
and that was a bit like your previous guest a few weeks ago, Abid Ali. I think he wanted to be a physio as well.
Yeah, he wanted to be a
Um,
physio.
yeah, but I didn't manage to get in
Okay.
with the sports science degree. So I started doing radiography and got into
Okay.
X-rays, and I've been doing that obviously for about 17 years before I went into ultrasound. It was in the while I was working as a radiographer that I first got introduced into ultrasound with one of the radiologists, and I fell in love with it straight away. I
Okay.
knew
What made you fall in love with this?
Yeah, well, he was a brilliant radiologist, actually. It was at the QE in Birmingham, and he introduced ultrasound as a bit of a fun tool. So you have this probe, and you're using it as a torch to look inside the human body, and you're trying to find clues and answers to the question and things like that. And I just thought that that was a great way to introduce ultrasound to me.
Okay.
And if you've got someone there that explains it to you and interprets the images for you, so you can get a good grounding straight away, it makes it a lot easier. And that certainly would grounded it for me.
Okay. So you first wanted to be um, in physiotherapy, but somehow you end up in doing sports. No, you first started off with
Yeah, I started with sports science. Yeah, and
and
it was the I like the sports side of it, sports injury side of it, and I guess that's why when going through X-rays and in ultrasound, I got introduced to MSK ultrasound, and I thought, oh, I can bring my sports injury passion back into this, and that's how it all started.
so
Um,
so when you did your postgraduate, I suppose you did your postgraduate course on ultrasound.
yes,
Did
yes.
you did you do a totally different degree, or did you start off a diploma
It was a postgraduate diploma
in
in ultrasound.
di- diagnostic ultrasound?
That's right. Yeah.
Right. From which university?
Oh, that was Central England, where it was
UCE.
UCE.
I went there.
Oh, yeah.
University of Central England.
Yes, that's
I'm
right.
talking. I'm talking about 1990. I was there. Different subject altogether. Software engineering.
Ah, okay, fine.
So I've got a bit of background in software,
Right.
right? So now, so you finished your course, and then you became diagnostic or a sonographer.
That's correct. Yes.
Now, if you want to explain me your role, what is sonographer? What is the role? What is the challenge? So I've got three questions. What
Yeah.
is so what is a sonographer?
Yeah.
Your role and you're challenged. So three questions, if you could give me.
Yeah. So sonographer is a person that uses ultrasound equipment to diagnose medical complaints, if you like, using ultrasound. And ultrasound for me, it certainly was difficult to get into because uh, the challenges that sonographers have when you're faced with it is trying to get into ultrasound, getting good training, good adequate training and mentorship. If you've got that to start with, it makes a good grounding, and you do need that to progress and get into it. Sorry, Somas, what was the other question you wanted?
The other one is the role of sonographer.
Yeah, so it's basically to use ultrasound to answer the clinical question, and then you use that to write a diagnostic report for the physician to.
And what was your challenge in that role?
I guess initially it's getting good training, interpreting the images. Um, the normal ultrasound was difficult to get into. I had to write a lot of letters and trying to get the interest, because they can't. They struggle to allow the mixing my words up here.
Yeah.
Struggling to get the adequate cover so they can release you to learn into ultrasound.
Learning. So did you work for after you qualified as a diagnostic sonographer or diagnostic ultrasound image person? Did you work for NHS? You did say you worked for NHS or something like that.
Oh, yes, I did. Yes.
Where was it? Is it in Birmingham or?
So yeah, so initially I worked at the Salioke Hospital,
Okay.
QE, and then it merged into one big hospital.
Yes, with QE.
Yeah.
Okay, and so you had quite a lot of practical.
Yes, absolutely. Yeah, I was a general sonographer for a long time before I got interested in the MSK side of it, and it's the MSK side of it actually that created the challenge.
Okay, now I'm going to come into that. Now you put me straight up to your question, right? what made you go? Obviously, with your background as a sports degree, I'm sure you've done bit of or understood about imaging, especially ultrasound, because on any sports courses they do touch a bit on MSK. Now, what made you MSK? What was the challenge, and why? What made you that you want to more go into the MSK? What was that triggered you, and what was the challenge you faced, and what did you enjoy the most? So you got 3 questions.
Well, I mean, I've always loved the sports injury side of it, so that's why I was initially interested to do the MSK. Now, the MSK is traditionally very musculoskeletal radiologist based, so it was quite a niche that they protected quite well. So to get into learn MSK ultrasound was very difficult, and I imagine I managed to convince them to teach me in stages. So start off with the shoulder.
Okay.
Learning shoulder ultrasound. But then obviously, as you get good at the shoulder ultrasound, you want to do more. You want to learn more. That's where the challenge came, because it's quite, as I say, it's quite a niche for the radiologists, and they don't like to let it go so much.
No, none of the medical profession want to let it go. But hey, if they can't hold on to many things, I'm sorry, the boat has left. The boat is moving. The world is going around, not in their circle, it's outer circle.
Yeah. So I did struggle, and I had to confront them one day and say, look, are you prepared to teach me the rest of the MSK? So this was just learning in the hospital. This wasn't any formal qualification or anything. This was just practical learning. And they said probably not. So they'd almost put a barrier up. Yeah. So I actually left the NHS because of that, which was a shame, because I actually loved that. I loved doing it. And I disappeared into the corporate world for a little bit, working for an ultrasound company.
Okay, selling the machine.
Exactly.
Good man.
Training to the end users as well.
Yeah, good.
Obviously missed the clinical.
Okay.
While I was doing that, I actually funded myself through the actual MSK course, and that was at Cumbria.
Oh, okay.
So I funded that myself and got all my MSK qualifications that way.
Okay.
And then I went part-time with the corporate side and part-time back into clinical.
Okay.
Where I was doing more MSK based, because I actually had the formal qualification then, and I had a route back in. So that was useful. But I learned an awful lot of non-traditional ultrasound while I was working for this company. I did a lot of echo ultrasound,
What is
emergency.
what is an echo ultrasound? If you could explain for
Oh,
novice like me.
so the echo ultrasound is using it basically ultrasound to look at the heart. So it's
Okay.
purely just looking at the heart. It has a different type of transducer, which allows you to get through the ribs. So it's a phased array, which allows you to shoot the beam through the ribs and allows you to see the heart, because the heart's hidden behind the ribs.
Okay.
Other things, emergency medicine, lung ultrasound was very interesting. A lot of it using today, actually, in the COVID-19 battle, they use lung ultrasound quite a bit.
Battlefield, yeah.
Yeah. So I really enjoyed that, and I got a good grounding of other aspects of ultrasound. So I also did a little bit of injection therapy. Now,
Injection guided.
injection guided. Now, being a sonographer, I was quite au fait with the ultrasound guided bit, but I wasn't with the blind injection therapy and everything else that goes with injection therapy.
You need Abid Ali and Mr. Mia and Martin Harvey. Those are our way injectors.
Yeah.
We go
But
blind.
So I did a little bit of that, but again, I faced barriers with that really.
Okay.
Being a sonographer, you don't have
Scope of practice. Yeah.
Yeah. So I mean, I could have gone back into a hospital and done
Setting.
under PGD and PSD and things like that. But again, I wasn't fully employed, so they weren't prepared to do that. So I couldn't really do
back to square one then.
Back to square one, yeah, indeed. So I set up my own company, and that's pretty much where we are up to date
at the moment.
At the moment, so I set up a company. I registered myself with the CQC.
Oh, the tough, man! I tell you, they're not easy.
Yeah.
They are bureaucratic quangos nightmare. I wish government made simplistic, and we should learn from COVID-19. You don't put obstacle for people to. Sometimes you have to let it go. Bring people in. If you put too much obstacle, what's the point?
Yeah.
Having all this rubbish regulation, I call it.
Yeah, but it's something. If I wanted to practice ultrasound outside of the NHS, it's something I had to do, and it was a regulation, because it's a regulated activity.
Yeah,
it was
certain activity.
Yes.
There you go.
It was illegal for me to practice outside it, so I had to do it. Okay. But I'm glad I did, because it gave me what I'm doing today and allows me to do what I want to do.
Okay, now let's come back to MSK ultrasound, because as you know, from podiatrist perspective, what you think because we'll come back to the role you play with Institutes of Chiroprators and Podiatrists, but what do you think it's for the podiatrists? Podiatrists are regulated profession, which you know.
Yeah.
Within our scope of practice, it is there. Okay, somebody said, Sohal Majid, hello, great stuff, thank you. Right, somebody say. So what do you see as a podiatrist perspective, if you put your what you call it, how do you see as a podiatrist with imaging? You know the question I'm trying to ask.
Yeah, I think so. I think
as a sonographer, how do you see within for podiatrists to use within their scope of practice?
Well, it's brilliant. I mean, it's something that you can pick up while you've got the patient in the room. You can put the probe straight on the patient, or you can do your clinical examination. Yeah, and anything you suspect, you can pick up the ultrasound probe, go straight to it, look at it, assess the tendon or the ligament or whatever you want to do, and you haven't wasted that time in saying, right, I'll send you for a scan, come back.
In America, they say podiatrist stethoscope is ultrasound imaging. What do you think of that word?
Yeah, it is. I mean, people are going to be walking around with the ultrasound machine just a pocket ultrasound machine and being able to do things like that, it's
It's
brilliant.
already there, isn't it? Pocket.
Yeah, yeah. I bought myself a portable ultrasound machine, and it's just brilliant. It really is.
There's a one called Butterfly I had, but now let me, while you are here, I need to
Yeah,
know about, people will probably ask that question, especially a podiatrist. What's the difference between the one I have, which is almost 15 grand, for example, a Sonotype E2 machine,
yeah,
and the one like Butterfly or people selling using like um, app? What
yeah.
is the difference? I'm sure there is a difference because money
There
is
is,
there. So if you
yeah,
could explain to somebody like me who's not knowledgeable, I've got a bit of knowledge, not that much knowledgeable, between the two systems. The one is 15,000 and the one which you can use your app.
yeah. A lot of it comes down to sort of processing power and ability. I mean, the technology nowadays is really really good, and I've used quite a few machines, and the quality difference is vast depending on where you go. I think a lot of it comes down to the crystals in the transducer, good quality crystals, good makeup, strong processing power, all these things. Or a lot of the processing things is done by algorithms and things like that. I mean, I'm not no techie with that at all,
No, but
really.
you got a bit of knowledge on that.
Yeah,
What are the pros and cons between the system like E2 machine, and then you got those? Because there's now a lot of them coming into the market, a handheld or app based. It's the transducer they need, and then they link with it
yeah,
app. But what I'm trying to say to you, I'm sure there is a pros and cons.
yeah. Well, in my experience, the ones that use your phone,
Yeah,
there is a distinct difference in image quality.
yeah, that's what I'm
Um,
after.
um, the temporal resolution, so that how this how the image moves on the screen, you will notice with the handheld ones that the image is a bit juddery,
Yeah.
and it's very difficult to interpret with that type of image degradation with the temporal resolution. But the the bigger machines have that ability and that power. And of course, if you're looking at a tiny little screen, if you're doing a whole list, if you just do one patient, just
Fair
have a
enough.
quick look. Fair enough. If you've got a whole list and doing a lot, like looking at a little screen, trying to see little tears in a tendon on a little screen,
It's
it'll be really really difficult.
So in your experience, it's best to go for even black and white machine, but with the slightly bigger screen, for then get used to it and maybe get into portable when you got satellite clinic.
Definitely, yeah.
So
The image quality is much better, and you'll be able to because you want a big field of view to
yes.
see your anatomy, see your landmarks, which you're going to struggle to get with your smaller machine.
Okay,
Um,
we got a questions now. Thank you, Sohal. What's the difference between body matrix? I never heard of the professional MX2000 ultrasound system and the normal ultrasound machine. I have no clue what he's talking about.
I'll have to confess, I don't either. I've not heard of either of those
Okay.
body metrics and
So
professional.
Hal, if you Majid, if you could slightly give us a hint what it is, and I think my friend can answer, whatever he knows. Thank you for the question, though. If you don't ask, you don't get. You know. Now, we've talked about the role of the sonographer, the hurdle you had. Now we talked about bit about machine. Now
Yeah.
let's talk about some terminology. My colleague,
Okay.
myself, we want to know what these 4 or 5 main importance terminology, or what we look for in MSK and the probe. What probe do we? Okay, somebody else asking a question before. How clearly can you see tear in tendons and ligament?
Ligaments. Very very clearly, depending on the machine and what you're using.
Thank you, Angie. Yeah, very clearly, as my friend said. Okay, where was I? I lost my questions. Right. What was the question I asked? I need to record back. Uh,
Oh, terminology.
yeah, terminology, please.
So
Hypo and all this.
yeah, the common terminology that we use are things like hypoechoic,
Yeah.
which is dark, hyperechoic, which is bright, or anechoic, which is black.
Okay, so repeat again. Hypo.
Hypo is dark,
Yeah.
hyper is bright,
Yeah.
and anechoic means there's no signal, so it's black.
Black.
Okay,
So
so
now what does these three mean?
okay, so fluid
Yeah.
will be black.
So that is
That would be anechoic.
anechoic. So black
Anechoic.
is anechoic. Okay.
Yeah.
Yeah.
Hypoechoic just means dark. So you can have something can be hypoechoic to something else,
Yeah.
but it doesn't mean black.
So one is black, one is dark, slightly different.
Yes.
And the other one is
Hyperechoic, which is bright.
hyperechoic, it's bright. So what do we look on that?
Okay, so things like bone,
Yeah,
okay, are going to be bright because
it's that line. It's that line I see sometimes. You know, between metatarsal heads, I can see like this
yes.
U shape.
So effectively, it's to do with the acoustic impedance, so the resistance to sound waves. Okay, so essentially, if you think of the sound wave coming down and hitting the bone, it gets reflected back. So more of the ultrasound is reflected back because it's a big acoustic impedance. So you'll get a bright picture.
So when we, for example, let's go for simplest. When we're looking for motor neuroma, for example, what would be this hypoechoic? What are we looking on that aspect?
So a neuroma is basically a thickening of the nerve.
Yes,
so I will look for the nerve, which will be it'll probably just be like a hypoechoic linear structure.
Which is hypoechoic is darker.
Darker, yeah.
Yeah. Okay. Yeah.
So the neuroma will be basically a thickening of that. So you'll have a hypoechoic linear structure for the nerve, and then it'll be almost like a bulbous hypoechoic area in continuation with that nerve.
Okay. So you could quite clearly see that darkest mark or darkish bulges if it's a proper neuroma, if it's a quite large neuroma.
Yeah, it's also it's important to mention that ultrasound is very, very operator
dependent. That's what I was about to say. What I may see, you may not.
Exactly.
Well, so the way you angle the probe as well, isn't it?
Exactly. Yeah.
Okay. Thank you.
So you need to know all the techniques to get good image quality and be able to see what you need to see. Because as you say, if you don't have the technique right, you could be looking all day and missing something.
Okay. So another question Angie is asking, what depth can ultrasound reach?
Okay, well, it depends which probe you're using. So if you're using the abdominal probe, I think you can get down to 30 centimeters now. But just remember that with the more depth that you get, the less your resolution and image quality will be. So for musculoskeletal, you want a very high frequency probe.
Is it linear probe they call it?
Linear probe, which that's with the straight edge.
Straight ahead, just like this, this straight ahead. Yeah.
That's it. So you want a higher frequency, because the higher the frequency, the better the image quality, but at the cost of depth. So you won't be able to get down deep. Okay, so you have to. Most transducers now are broadband, so they have a range of frequencies, so you can select within that range. So on the transducer, it may say 1 to 5 for the abdominal, or it may say 4 to or 6 to 18 for the linear.
Yeah,
that's the frequency range.
So which is the ideal? Is it 15 is ideal for transducer? Yeah.
Anything above 12 really
It's
um,
ideal for MSK.
is ideal for MSK. So,
Okay.
for instance, if you know, I classify sort of hernias
Yeah.
scanning as an MSK type thing. So
Okay.
it's quite deep than your normal MSK. So I'd probably want to use around a 12 megahertz to look for hernias and things like that.
Ec- Excellent. So we've talked about now bit of terminology and bit of which probe to use as a MSK. Remember, we're talking today slightly more on MSK
Yeah,
and the benefit as a podiatrist, which my colleague Adrian say it's a nice tools to have. It's an assessment, isn't it?
yeah, absolutely. Yeah,
It's to aid more to aid you more or less diagnostic to find something slightly on the deeper hand, deeper knowledge. Don't wouldn't you agree on that? Would you agree on that?
yeah, definitely, definitely.
Okay. Now we are now coming back to the role you are playing with institutes of chiropodists and podiatrists. If you can if you can just expand that, you did first I would say, course with us. How
Yeah.
did it go? And what do you think? Again, how did it go? What do you think? And what is the future with IOCP and yourself? And what course, this course, what would enhance them?
I think the course was brilliant. I think the people on the course that came thoroughly enjoyed it. They got lots of hands-on scanning, which is important. If you're using ultrasound, it's important that you use and regularly scan things because you can lose that technique and that skill if you don't keep it up. So yeah, they came on the course. They enjoyed it. They got good anatomy, pathology correlation with the imaging. And that's important too. So to have someone by your side going through the technique while looking at perhaps the pathology or the anatomy on the screen, you know, it can orientate it in your head a lot better because ultrasound tends to be quite difficult to interpret if you just try and look at it for the first time. So you need that sort of anatomy picture help maybe. Um,
Picture, picture explains thousand word.
yeah, exactly, perfect.
And 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 I would say from podiatry perspective, it's also best to understand slightly better anatomical images and the know about ligaments slightly a next step of knowledge. I'm not saying that it's not totally novice. It's better to picture the image in your head, isn't
Yeah,
it?
yes,
So if you understand anatomy of or anatomical landmark, then I think it plain. You know what I'm trying to say.
yeah,
If you know what the ligament is, where they are,
yeah.
and if you know slightly deeper knowledge, when you put the image on, it shines in your eyes. That's the word
Yeah.
I'm trying to.
Yeah. I mean, I'll tell you now, all the years I've been scanning,
Yeah,
it's very difficult to put the probe directly on, say, the middle of the thigh and know which
exactly. Yeah.
muscle it is. You have to go back to your landmark, a bit more distal, a bit more proximal, and then follow it down. And it's having that skill to know where your anatomy goes and to correlate it with what it looks like on the screen that it helps you.
Because you are an associate tutor with Abid Ali
That's correct.
on our course, and last course, as I said before, COVID-19 was a successful course we had. You had quite a lot of podiatrists in your course,
Yes.
right? Their feedback was brilliant, by the way, right? Because they had hands on two practitioners, hands on knowledge about the lower limb, right? How do you see we can further progress the Institutes of Chiropodist and Podiatrist approved ultrasound diagnostic course? How can we further improve, or what else could you bring or add to our future course?
Um, I think what everybody likes to see is pathology. So being able to, I mean, obviously you have to get patient consent and things like that. But if you could find a way of getting patients with pathology to come to the course so they can scan and see pathology, that's a big thing because
So we need to look for a patient, by the way. Any patient in there, listen, next time we put course on, just give us a tinkle and we'll have you in. Right. So We talked about our course as well. As I said, because of COVID-19, it's now on hold. Our Institute of Chiropodist approved course. It's two-part. First, you do theory online, then you do practical, right? Then we soon, Abid is thinking to do master class with you, like to knees and
Oh yeah,
so on.
yes, yeah, yeah. No, we can do that.
And and guided injection where you said you had a difficulty as a podiatrist, we inject anyway, so there won't
Yeah.
be any difficulty for us. Right. Before we go, any hints and tips?
Well, if you can get yourself a lot of hands-on with ultrasound, that's recommended. Find yourself a good mentor that's willing to guide you and teach you. Know the anatomy, the insertions and origins of your anatomy very well, because that will help no end. And then just see lots and lots and lots of normal scans. And then if you get that pattern recognition of normal, then when pathology is there, it jumps out at you. And that's
So what you're trying to say is not about the qualification you'll hand. It's a practical.
absolutely. Yeah.
This is not like PhD in ultrasound.
No.
This is practical.
Yeah, the course is the stepping stone. It's the experience and the practical afterwards that will make you go,
wherever you want to go.
Yeah, exactly.
Right. One more question I have, my burning questions, is do you know anything about, there's a lot of misconcept going around, the my way is the best way or his way is the best way. But do you know anything about case approved?
Oh, I knew you were going to say that.
Because a lot of people just bombard with that misnomer, and I just say, I can't take it anymore.
Yeah, no, I would. I mean, I don't know much about case, to be honest. I know they do a lot of accredited courses and things like that. But if you basically get good knowledge from good sources, with experienced sources, then that's as good as any.
There's our friend Celtic SMR Healthcare is our sponsor of the course, by the way. I'm sure you met them last time.
Yes.
Yeah. Thank you. It was a great course, and really looking forward to the next one. Next one, we're getting people from all over the world to come to our course. We're having yes, but we can only choose a registered practitioner, right? Thank you. Is it Celtic or Celtic? I don't know what to say. Is it Celtic or Celtic? Celtic SMR. Okay, Angie again. Thank you. Now you are making me regret leaving the IOCP. I'd love to do, as this is, of course. Hey, I don't want to play any political banter. I don't want to sell IOCP, but it's a choice. It's best to have a choice. I always believe freedom of choice. I don't like to be dictated by one club or one organization to another. Every one of them has their own individuality. Every one of them has their own weakness and strength. And my golden rule is you design your own destiny. Nobody should dictate you any destiny. If what I call myself, I call it. I don't care whether you can't please everybody, you can't like everybody, and no course is perfect. I always say any learning, it's you, it enhances you. Whose course, this accredited, that accredited, to me is irrelevant. Long as I do a course and I imply my knowledge, and that's the best God can give it to me, is the knowledge I create. That's all. I don't know how better I can say it. Is there any way you could say anything on that, Adrian?
No, I think I agree with you. I think as long as you're getting good experience from people that know what they're talking about and stuff, then it doesn't really matter where it comes from. And then you put that into practice, and then that's what you need.
Yeah, but as I said, with us, our course is insured through IOCP as a group insurance. So and as a regulated professional podiatrist, it's within our scope of practice, right? Just like seeing any imaging, right? It's far less toxic than radio X-ray.
Yes,
because you're not passing anything on to them. Right. So Any final message you want to give it to a podiatrist or any layman's who's watching us throughout the world?
I'd definitely say if you're not or using ultrasound at the moment as part of your practice, then I think you're missing a trick. You should be, because you can have the patient in your office at the time, and you do the scan and give them a whole diagnosis there and then within 10-15 minutes, and it'll speed your throughput up, and it's an amazing modality to learn, because once you learn one thing, you'll want to learn something else and something else and something else. It's a great thing.
It's called Celtic SMR. So I'm learning. It's Celtic. Thank you. Right. Thank you, Adrian. And it was lovely to have you on the platform.
Thanks for having me.
From a sonographer's perspective, not a podiatrist perspective. And we all here to learn. Like as I said, learn and earn. The more you learn, the more you earn, right? Regardless of what you are, who you are, my famous philosophy is you design your destiny. You go to the course which suits you and benefit you, right? Regardless, right? And that's it. The more knowledge you have, the more better outcome or better patient perspective or better treatment plan or treatment, design the treatment for your patient. That's how I see it, right? Knowledge is power, right? We have to nourish it. It doesn't matter where you get it from, how you get it from, who you get it from. It's yours. Nobody can take that away from you, right? So end of the day, Adrian, thank you very much. Without you, this platform would have been nice. And I'm sure next time I'll probably come. I'll see how this program goes. If there's a demand for case study, we'll try to bring a case up. Probably they'll learn far, far better.
Yes.
Yes. And if anybody want to know about the terminology Adrian talked about, it's there. It's recorded YouTube in here. You can go in. Terminology is absolutely important. If you want to write or when you refer a patient to another colleague, you need to see what you find, right? And that's the terminology you can use. Thank you very much. Thank you for everybody watching it. And as I said, if me or Adrian have said something which doesn't, it's irrelevant, or we said something which is wrong, please advance apology, forgiveness. As a human being, we are human being, we can make mistake. So advance apology. So next time we'll see you, and good evening everyone, and bye bye.